and IA for the opportunity to be here, and thank the Mass AITC team for organizing this workshop and bringing us together. It's an impressive group of researchers, clinicians, and innovators, and it's nice to be able to provide a little opening remark today. As Deepak said, I'm a program official for the AITC at the National Institute on Aging, and I must tell you, being here for Becky and I is one of the most energizing parts of our work. It's certainly cold outside. I was trapped outside for a little bit earlier, but it is warm and exciting in here. As you all know, the AITC program is dedicated to helping Americans live longer, healthier lives through the application of artificial intelligence and emerging technologies. The driving goal behind the program is to leverage AI and technology to address challenging problems and develop practical solutions that benefit older adults, caregivers, healthcare professionals, and our healthcare system more generally. Today's focus on frailty is not only timely, but it's also essential. As you all know, frailty affects millions of older adults and fundamentally impacts their ability to live independently, maintain dignity, and enjoy quality of life. Behind every data point, there is a person, a family, a caregiver navigating incredibly difficult challenges. So the work you're doing here isn't just advancing science, but also rippling outwards and changing lives. That has deep meaning, and I hope you take a moment to reflect and recognize that. What's so important about the opportunities to see how AI and emerging technologies are opening new frontiers is it's showing us how we can help. For instance, early detection and screening, the power of AI and machine learning to analyze diverse data sets, such as electronic health records, wearable sensors, and gait analysis means we can identify frailty risk earlier than ever before. Continuous monitoring and assessment. Wearables, home sensors, and mobile health tools are revolutionizing how we understand frailty. We're moving beyond the episodic clinical snapshots to seeing how people are doing in their daily lives in their own homes. And that real-world understanding allows us to catch subtle changes and personalize care. Then lastly, intervention and prevention. From digital therapeutics that promote physical activity and cognitive engagement, to clinical decision support tools that help providers optimize cares, to technologies that support aging in place. These innovations are helping people maintain their independence and quality of life. So I just want to reiterate, I want you to know how important this work is, the research you're conducting, the technologies you're developing, the partnerships you're building, and that allows us to create a better future for those in the aging environment. As funders of aging research, we're proud that NIA's investments go beyond technology to championing this future where innovation serves humanity, where science translates into real-world impact, and where every older adult can thrive. So thank you for your dedication, your creativity, and your collaboration, and your commitment to this important work. I'm very excited to learn from today's presentations and to discuss how we can continue to push forward at the digital frontier on frailty. The work you're doing here matters, so let's make the most of today. Thank you very much.
Okay, thank you, Joe, for those remarks. So I'll make, give some quick opening remarks, and we'll continue with the program. So just to introduce, Mass AITC is a consortium with a number of universities across and hospital systems across Massachusetts. We have a number of people from here. I'd ask you to raise your hand as I introduce you. So I'm one of the co-directors. Benjamin Marlin and Sudeshna Das from MGH are co-directors as well. Margie Lackman from Brandeis is our Aging Pilot Corps director. And we have, I also want to call out Day Kim, who really helped us put together the program. Day Kim is from Hebrew Senior Life. And I also want to introduce David Paquette, who is our associate director, and two of our administrative managers who may or may not be here, Caitlin Hankin and Suzanne Rataj, who put together this program. So you can talk to them if you have any questions, logistics, and so on. So the AITC program, our Mass AITC, our goal is to foster development and research in using sort of cutting edge wearable and sensor and AI technologies in the space of healthy aging, but specifically for the home setting for helping older adults and individuals with Alzheimer's. And so the reason we put together this workshop on frailty was largely because there's this confluence, and the reason, and so I should mention that Mass AITC is one of the AITC, one of the members of the AITC P30 program. There's a few others. John Hopkins is one, and Penn is one as well. And in the space of aging at home, we are supporting a large number of pilot projects. There's about 40 to 50 at this point. Largely focusing on academic plus industry collaborations. So we've got 50 to 60% industry representation, and the rest is academia. And we're focusing on a lot of topics that are relevant to aging at home. Cognitive function, longitudinal measure of cognitive function, improving care at home, fall risk, physical function, and so on and so forth. And so I wanted to sort of say a little bit about how we came to this. So part of the reason why frailty was a very important topic is because on one hand, you have the clinical need to continuously measure at home. Right? And on the other hand, you have sort of this inflection point in technologies where the capabilities, the ability to measure at home is increasing as well. So when these things come together, I think there's a big opportunity to make an impact in this space. And as I was thinking about how to maybe frame or level set what we might get out of this, where we might go with this. What might be an analogy where, where in some other domain, perhaps, we've seen successes. One thing that came up is successes in in a completely different field, which is athletic endurance monitoring, which I'll say has some parallels to this, and I'll just maybe briefly touch on why. So if you look at modern day athletic, obviously it's very different from frailty, and I'm not suggesting this is the same problem. But if you look at that domain, where there's been a significant impact in the last several years, you have this mixture of, you want to measure individuals' response to stressors. You want to see how they recover and what their personal baseline is. And you want to suggest something, how they might change, right? And there are many startups and so on, including ones in Massachusetts, like Whoop, which is what's shown here, which take athletes through this pipeline, right? And what's instructive, perhaps, for this domain is kind of, what I found instructive at least is how you go about something like this, right? So the first step of something like this is to know what to measure. You have to find these measures that correlate with what you're interested in, right? That move with what you're interested in. So in the case of stressors for physical activity, you want to find, this is heart rate variability ended up being the measure of choice, one of the major measures of choice. Heart rate variability changes as there are physical endurance type of measures, but it also changes with health and sickness and heat and so on. So it moves along with the things that you want to measure. And so the next step, that's step one. And the step two is to then figure out what's a personal baseline. Right? So you establish a personal baseline for this individual, and then you have the measure, you establish a personal baseline, and then it's as simple as, step three is as simple as finding out how people are below or above the baseline. Right? So you have a stressor, below the baseline, then the recommendation might be to reduce it. And the recommendation, if you're above, would be just keep going with what you're doing or increase it. Right? And so this pipeline of, and this is sort of at an abstract level, this is obviously very different. Frailty is much more complicated, many more stressors, many different, confounders. But at the same time, it provides us a template. Right, provides us a template of if we could establish what we want to do, what we want to measure, come up with individual baselines, we could actually get to action, right? And you see this pipeline being replicated in other ways, maybe with less or more success, right? So for example, if you look at closer to us, if you look at cognitive health and how that's going, you have companies like Linus Health out here and others, which have a measure, clinical clock drawing test as being a score. So you have clock drawing test as a score. If you're able to measure something like that over longitudinally every day, let's say, or every few days even, then you are getting some kind of a profile. And then if you have an individual baseline that you can establish for them, then you're getting into the realm of being able to suggest sort of action. Right? So this as and I think to me the question coming in was, can we build this analogous stressor recovery action loop when it comes to frailty? Now, we'll have experts in frailty talk, and they might say that this is entirely not the right way to think about this problem. And I think we'll have a robust discussion today about this. But I think it will, when you want to measure something, you want to first figure out, you have to define the problem itself, and that's what they will do, right? Define the problem, define what are the aspects of frailty that we need to measure. And then how do we measure them? How do we actually go about it? And are we ready to measure all of the things that we need? And then, of course, the next step is like getting from the measurement to improving decisions and the outcome. Right. So hopefully across the day today, we'll have a robust discussion in all of these three aspects, right? Defining the problem, understanding how we can measure various facets of it. What are the key things to measure? What's ready and what's not ready? And then, what do we use that information for? Who are the stakeholders and how would they use this information? So with that, I'm going to transition. I'm going to hand it over to Ben Marlin to walk us through the program, as well as give us a sense of kind of the bag of tools we have. I mean, even if you look the last 5 years, the bag of tools we have, both technology-wise and AI-wise, has expanded dramatically. Right? So things that we can bring to bear to address this problem. So walk us through that. Thank you.
All right, thank you, Deepak. So as Deepak said, I'm going to start just by giving a quick overview of what the program is for today. So we're in opening remarks at the moment. The first session, Dr. Dae Kim will speak focused on defining frailty, as Deepak mentioned. In the second session, we'll have a presentation on candidate measures for digitization. We'll break for lunch, so the icons here are what's online for folks who are joining us virtually. First three sessions will be on Zoom. We'll break for lunch in person. We will have poster viewing and device demonstrations from 1 to 2 in the afternoon. And some of the posters and some of the demos are available online for folks that are joining virtually to have a look at over that period. We'll resume with a plenary session from 2 to 3. Dr. McRae will speak on frontiers of measuring functional reserve. We'll have a brief break and then come back with moderated discussion to have a rejoinder across the different topics and discuss the points that Deepak mentioned in terms of how to advance in measurement and think about intervention. And we'll conclude with some closing remarks followed by networking reception. So as Joe mentioned, and as Deepak mentioned, there's an interesting opportunity right now in the technology space. I think what we'll hear about in the first session this morning is that frailty is a very interesting and multifaceted construct. In the technology space, over the last 5 years to 15 years, we've seen significant advances in different types of technologies that at this point we think are primed to be brought to bear in this problem space, starting with commodity wearables, Fitbits, Apple Watch through slightly more recent advances, so smart rings, smart earbuds, smart glasses, and so on, that are commercial off-the-shelf technologies that you could grab and deploy right now. There's a space of more clinically focused wearables that are looking maybe at some measurement of more difficult to acquire physiological signals in a bit more specialized way. There's an interesting space of at-home and IoT technologies that are not wearables, but that are maybe ambient sensors that you might think about placing in a home. There's another category around kiosk-like devices that you might think about putting in a place like CVS or Walgreens, where someone could come in and take a measurement periodically. So lots of different technologies that are deployable outside the clinical space. They are capable of measuring lots of different things with different fidelity. So lots of these different technologies have applications for physical activity, for cardiovascular system monitoring, for sleep, for nutrition and metabolic measures, for cognition. So there's a mapping between sort of these devices and what they're able to measure. Lots of interesting work going on, including in the space of research wearables. Some of our pilots are in that space, and then research on new kinds of measures. And so the way that we think about this space is sort of how ready are these technologies to be deployed? So we can think about categorizing them in different ways. When we're looking at some of these measures, some may have high accuracy, so they're very close to whatever ground truth you might think about. Some may be highly reliable, others less so. Right? And particularly for this application, frailty, what's salient is how accurate and reliable are the measures in an older adult population. Right? And so when we're thinking about devices like a Fitbit that are targeted at a general wellness sort of fitness market, they're not necessarily able to reliably pick up, for example, steps or gait for an older adult who's maybe walking with some sort of assistive device. Right? So even though some of these modalities may be ready to go for a general population, perhaps not in this space. So thinking carefully about what's actually accurate and what's actually reliable and what evidence do we have to support those decisions is important. Right? There are additional factors like privacy. So we can do things like put cameras in people's homes and use computer vision algorithms to look at different kinds of activities. That's not a particularly privacy-sensitive approach. Right? So there may be some things that we can measure, but not necessarily in a way that has some of the properties that we would like. When we're looking at wearable technologies, usability is important. So we might have a very cumbersome technology that in the lab we can pull very accurate measures out of, but it might not be something that's really ready to be deployed in someone's home. And of course, cost is an important consideration as well. Right? So when we're thinking about the different aspects of frailty, how we might measure them, we can sort of line that up against different kinds of devices and technologies, but these considerations sort of underlie what we might actually contemplate deploying in practice or deploying in a research study. Complementing the device technologies, of course, we've seen the emergence of AI as a sort of consumer technology over the last several years. The form of AI that's most prevalent at the moment as a consumer technology is generative AI. So we're talking about things like large language models, for example, ChatGPT. That category of technology is really good at doing things like analyzing text, for example, less sort of suited to doing things like analyzing multivariate time series data, which is what you would get if you took a sort of suite of these device technologies, use them to collect intensive longitudinal measures, and then we're interested in a problem like inferring an overall sort of summative frailty index. However, the technology that underlies constructing large language models is something called foundation models. It's a particular large data technique in machine learning that's designed to sort of be trained once on large data and then fine-tuned for specific applications. So in the last several years, again, we've seen specific foundation model ideas around time series, specifically time series data from wearables or from clinical sort of ICU, EHR type of data being constructed that are out there and are something that are potentially leverageable in terms of taking, let's say, lots of measures and turning them into maybe a accurate and reliable overall frailty index. The large problem in this space is often data volume. So the foundation model idea allows you to take a large pre-trained model and fine-tune it against a specific task. And of course, in machine learning, which underlies both of these as a core methodology, there is a rich history of approaches that are designed to build models from limited data. Right? So often, especially in the pilot sort of phase of research that we support through Mass AITC, we're running relatively small studies. So people have 50 participants, 100 participants. And the question is, how can we maximally leverage the information that we can collect from those participants to move the field forward or move an idea forward, a hypothesis forward about what might be a useful measure or a useful score. Right? So there are interesting technologies that are not foundation models, that are not generative AI in machine learning that can support that as well, such as Bayesian deep learning for folks that maybe are on the CS side. And of course, with AI, there are a whole number of challenges as well. I've mentioned data scarcity. There are a lot of challenges here building new machine learning models completely from scratch. So the commoditization we've seen around foundation models addresses this to some degree. If you can find a pre-trained model that's close or closer to what you're interested in building, then that type of approach can allow you to do interesting things with limited data. In the absence of such a foundation model, again, there are approaches in core machine learning that can still be brought to bear. So as we move forward through the day, this is just a bit of a quick primer in terms of what's out there in terms of device technologies, how to think a little bit about the AI machine learning space that could be applied on top of those signals as we push towards new measures and new types of scores. So I'm going to stop there to conclude the opening remarks.